Well, welcome everyone. It's Meg Jardine from the University of Sydney, and Rajiv Agarwal and I have just come back from the American Society of Nephrology Kidney Week, which was a really stellar conference this year. Rajiv?
Yes, I'm Rajiv Agarwal. I'm a professor of medicine at Indiana University School of Medicine. It was such a wonderful meeting, especially after a hiatus of several years. It was great to meet our friends. Unfortunately, I missed meeting you, Meg, at the meeting. And I'm delighted to see you live today on Zoom across the globe. And let's get on with the Congress highlights.
Yes, and there are some terrific highlights. I think there are a few things saved up. So firstly, we should mention our disclosures. So it was a different conference, wasn't it, Rajiv? It was a hybrid congress, but we still had many thousands on site with a few people accessing virtually. And I think you still can access the slides and presents virtually if anyone interested wants to take that one up. There were a couple of high-impact clinical trial presentations that particularly drew our attention. So we might take a couple of moments to talk about them. The first one was, of course, the EMPA-Kidney study about empagliflozin for patients with chronic kidney disease. This was the third of the dedicated renal trials that were looking at the impact of SGLT2s, and I think there are a lot of people who are anticipating this presentation. So Will Harrington from the University of Oxford presented on behalf of the EMPA-Kidney collaboration. And the rationale, of course, was that we've had large placebo controls with patients with diabetic kidney disease and albuminuria that have, including the Credence trial that we were both working on. And they showed that on the background of RAS blockade, SGLT2 inhibition prevented the progression of chronic kidney disease. And of course, we've also had the large finerenone studies, Fidelio and Figaro, that showed that the non-steroidal finerenone reduced the progression of kidney failure. However, neither of those studies, including people with a normal levels of albuminuria or very low levels of albuminuria, and there, 1/3 of the patients in DAPA-CKD had diabetes, but other than that, people without diabetes haven't been present in those studies. So on that background, EMPA-Kidney was really designed to look at the impact of empagliflozin in people with a wide range of chronic kidney disease at risk of progressing to end-stage kidney disease, particularly those who hadn't been represented in the previous trials. That's people without diabetes, people with eGFRs less than 30, and EMPA-Kidney recruited down to 20, and people with normal or low levels of albuminuria. So it really supplemented the evidence we have so far. So in particular, that eGFR of 20 to 45, regardless of whether you had any level of albuminuria or not. And they also included people with eGFRs of 45 to 90 with urine albumin creatinine ratios of 200 milligrams per gram or greater. And all of them had to be on at least on one single RAS blocker. So they were randomized to empagliflozin or placebo and followed to the composite renal outcome. That was a combination end-stage kidney disease and death from kidney or cardiovascular death. And in that, it was common with the previous kidney-dedicated trials. But there's also in the composite a drop in sustained eGFR of 40% decline. And that was a little bit of a lesser decline than the previous studies. And that might have had an impact on some of the results.
So one of the point of clarification, Meg, even though they say that they received a single agent RASI, I think what they want to say is that they weren't allowed if they had a dual agent. It wasn't a key requirement because there are about 15% of the patients who never were on ACE or ARBs. Right.
Yes, of course. So not dual ACE and ARB. Yeah. Good. That's
because when we were doing Credence or Fidelio or Figaro, everybody had to be on a background ACE or ARB. This wasn't a requirement, was kind of a unique feature of this study.
Yes, you're right. It makes it a bit similar to the large cardiovascular outcome trials, doesn't it? Which ended up with 70-80% of people on RAS and some who hadn't. So really, this now includes people with CKD who are not tolerant of RAS, and maybe that's another extension. That's a good point. So the study was underway, and then in March 2002, at an interim analysis, it was stopped after having met its goals for efficacy. And so that's meant we've had 7 months of waiting for the results. Because it was stopped early, it meant it had a shorter follow-up than originally planned, with a median of 2 years. And that's the shortest of the large SGLT2 inhibitors trials, but the kidney ones, I should say. So all of them, though, they had a follow-up of between 2 and 2.6 years. So these were the patients included. They had a mean age of around 64, around 1/3 were female. In that respect, they were fairly similar to the previous kidney-dedicated trials. Around 45% had diabetes, so that's a lower proportion than in DAPA-CKD. But I think the really significant difference from the preceding trials was the kidney disease characteristics. They had a lower GFR than the previous trials of 37 mils per minute. And the number with an eGFR less than 30 was 1/3, around 34%. And that's a marked difference from the previous trial. So it's well and truly extending that eGFR band down. And their albuminuria levels, the median was around 330, and in that respect also they were lower, although they still included some people with substantial albuminuria.
You know, so this is one thing to emphasize, like you pointed out. There are no trial in the past, whether it has to do with an SGLT2 inhibitor or non-steroidal MRA, has included people less than 30. So these are people without albuminuria, data-free zone, and they're about 1,300 or so patients. But that's a very important subgroup. And that was, again, a place that we were hoping for a big signal there. You know, it's a data-free zone.
Yes, exactly. Yeah. DAPA-CKD did have some down to 25, of course, but they all had substantial albuminuria. So, yeah, this group is quite unique in those big trials.
I meant 30 milligram per gram albuminuria, right? Because EMPA, the DAPA-CKD stopped at 200.
Oh, sorry, I thought we were talking eGFR. Absolutely right. Yes. Yeah, no one less than 200, which is quite substantial. So yes. This was a few patients, I guess, in the large cardiovascular outcome trials fell into this, but on the whole, those trials were conducted in people at low kidney risk. So that does make this a really important trial.
Yeah. And, you know, especially because, as you pointed out, the people with the less than 45 stratum were the ones without albuminuria. They were still at high kidney risk, but they were without albuminuria. So if you had a GFR more than 45, they did require UACR to be more than 200. But none of these people that are you're showing on the slide, or very few people, would have a GFR more than 45. These are all people with fairly advanced kidney function. And in a way, they're asking, is it too late to intervene, right? Because you have less than 45 GFR and no albuminuria. Can you still repair the kidney with a SGLT2 inhibitor?
And of course, with a majority without diabetes. So it makes it the first trial in the kidney dedicated trial to be looking at that group. And that's really extending.
Very heterogeneous.
Yeah. Okay, and so the results, I mean, we knew because it had been stopped for efficacy, we knew that there was a favourable result, but it was, I think we were all anticipating how strong it would be. And so for the composite, reminder, that's end-stage kidney disease, kidney cardiovascular death, or a 40% drop in eGFR to an eGFR of less than 10, and a clear benefit. There's a hazard ratio of 0.72, that's a 28% reduction. And you can see the results on the slide there. I think in interpreting this too, it's worth remembering that the trial was stopped early with a median of 2 years. So what were your thoughts when you saw that, Rajiv?
Yeah, so, you know, what I think that we already kind of knew that the trial is positive because it's been stopped for efficacy. So there were the groups of people that we are just chiming in about, what happened to people without albuminuria? What happened to the people without ASO ARBs? Are these still protective drugs? I think those were the subgroups that we would be most interested in.
Yes, I think that's right.
Old news, right? I mean, it says, okay, if you told me SGLT2 inhibitors are not working, we won't believe it.
Yeah, yeah. I thought it was interesting to see that the effect size was, pretty consistent with what we'd seen. But you're absolutely right. It was the subgroups that I think everyone was waiting for. So let's move on to them. So firstly, the diabetes subgroup, whether people had diabetes or not. And on this trial, we didn't get the p-values for heterogeneity reported there. So those statistical reports weren't presented at the main session at ASN. But what you can see is that numerically, there was a strong effect in people with diabetes. I thought that was interesting because it harks back to some of those DAPA-CKD studies that showed in DAPA-CKD that the effect was stronger in people with higher levels of A1C, but there still was effect in people who did not have diabetic kidney disease. And I think that's what we're seeing here, with each group individual significant.
It was a little bit surprising, wasn't it, Meg? Because, here they reported the p-value in the session as 0.06. So it was almost significant. If it was 0.04, it would be significant. But you can see almost half the effect size in people without diabetes, and was opposite of what was seen in the DAPA-CKD. In DAPA-CKD, there was a greater efficacy of dapagliflozin in people without diabetes. Mm-hmm. So I was a little bit surprised. I don't know if I understand why the differences in the
field. There was one of those the secondary analyses of DAPA-CKD where they modelled the effect of HbA1c and effect size, and on that modelling at least, the effect size was getting stronger as HbA1c went higher. So my thought on this is that what it represents is a lot of people without diabetic kidney disease still might have abnormal glycemic control or pre-diabetes, as we used to call it in the old days. And so that, unless you've got a really well-controlled glycemic milieu, that these agents are likely to be of benefit. Certainly they're of benefit in the majority. And I think that says it all. Yeah. So then the other interesting thing, of course, was the EGFR subgroups. Now, we had seen from the previous studies that the effects seemed to be consistent across EGFR subgroups. But what was really pleasing was to see that confirmed again, because as we were just saying, Rajiv, we had a lot of people in this trial with EGFRs of less than 30, and just looking at those subgroups look identical. But then the one that triggered maybe the most chatter during the conference was the effect in albuminuria subgroups. So for this outcome, the composite dichotomous outcome, there numerically was there to be a neutral effect in people with albumin-creatinine ratios of less than 30, with stronger effects as albuminuria rose. Now, there was a little bit of a disconnect with the EGFR results, wasn't it? Where the chronic EGFR progression showed benefit in all three groups. Now, there are a few theories around what the explanation for that might be. Rajiv, I don't know if you wanted to chime in on that.
Yeah, I think that, it's possibly has to do with the trial design, right? Because they included people who had a GFR more than 45 when the USCR was more than 200. So the people with less than 30 and 30 to 45 can have macroalbuminuria. It's not like they cannot have macroalbuminuria. They can have macroalbuminuria. So my interpretation is that the people who are less than 30 or 30 to 45, the results are driven by people who have higher levels of albuminuria. So what you have to do to understand this is to do a joint analysis and not show the independent of GFR and USCR, but they showed the p-value on the interaction effect on USCR, and that was 0.02.
Yes, that was
right? That was
significant.
the interaction p-value.
Mm.
And to me, it suggests that UACR is influencing the effect size of the trial.
Mm.
And I don't think
Well,
that.
I think it's,
Yeah, go ahead.
yeah, I think it's still a little bit controversial because they also showed the EGFR, the chronic EGFR decline, and that did show a benefit in that group with no albuminuria. So, you know, I think there's a possible range of results. It may be a true positive, but similarly, it may be that in this group with no albuminuria at low risk of progression, it may be that 2 years just wasn't long enough. And that if the trial not been stopped earlier, we might have seen a different result there.
Yeah, I think that this is the one that is generating the most amount of controversy is how do you look at the data, right? Now, if a trial that is stopped early, median follow-up of 2 years, you don't have people who are long-term follow-ups. And when you do a long-term follow-up, that's when you get the best slopes. There are possibly people who have very short follow-ups, and in them, the slope estimation is not very accurate. When I look at the data on the placebo group in the less than 30 UACR, their rate of decline of GFR is actually less than a healthy person. It's less than 1. And when you look at the treated group, it's like 0.14. I said, oh, I'm going to have immortal kidneys if I take this drug, right? Basically, they are showing that there's 0 progression with no albuminuria.
Yeah.
So I think that we have to be cautious because this was the primary endpoint. The primary endpoint is modified by the level of albuminuria. My question is that would you change your practice based on this trial? In other words, if you had a patient, say, with hypertensive nephrosclerosis and has a GFR of, say, 35, no albuminuria, would you start the patient on a SGLT2 inhibitor?
I think, that's a great question. I think there is still some more information to come. I know they're going to be following these patients for longer, so it might be with a bit more time, that there's enough time for events to accrue in, as you say, a low risk group, and we might see a difference. Of course, in the meantime, there are the other benefits of the drug for heart failure in particular and for cardiovascular events. So look, personally, I think there's still a real net benefit that's likely, but you're right that the benefit for kidney disease progression is not as clear. This does hark back to those DAPA-CKD studies that did show albuminuria did seem to predict a stronger effect. Those ones didn't have people with no albuminuria, so weren't able to answer this question. So I think there's more analyses to come. Perhaps some of the analyses that can be pulled with the cardiovascular outcome trials that also had people with no albuminuria. Whichever way it washes out, though, I think the overall message is for high albuminuria, it's very clear cut. Those patients are high risk and definitely get the best absolute benefit from an SGLT2 inhibitor.
Yeah, I completely agree. I also agree that if a patient has a history of HFpEF, HFrEF, these drugs are indicated.
Yeah.
If there's no prior history, just uncomplicated diabetes, but has kidney failure with no albuminuria, I think we still have to scratch our heads to see if you really want to put the patient.
So of course we are talking about one subgroup, aren't we? And we have to be a bit careful there. The overall message is these agents look really effective for SGLT2 inhibitors, which has been a fantastic advance on where we were 10 years ago. So we'll just break down those components for the sake of completeness for the primary outcome. So we had the progression of kidney disease. You've got the rates there. The overall hazard ratio 0.71, a near 30% reduction in risk. For cardiovascular death, the hazard ratio numerically was consistent with a 16% reduction in risk, although it wasn't individually significant in its own right. Fairly low events, as you see there. And for end-stage or cardiovascular death, the hazard ratio was 0.73, 27% reduction, and that was significant in its own right. So I might move on. We have a lot to cover today. Sorry, I've just whizzed past those secondary events. So, of course, hospitalised heart failure or cardiovascular death. For me, this is one of the outstanding features of the SGLT2 inhibitor story. Remembering that these agents were started for glucose control, I don't think anyone really expected how profound their effects would be for heart failure. In this study, the patients were relatively low risk for heart failure. You can see there the rates, two to 2.5 events per 100 patient years. So a lower risk than some of the other renal dedicated trials, and a hazard ratio of 0.84, which wasn't separately significant. Hospitalisation for any cause, rates of course higher here, 25 to 30%, and there was a significant reduction of 14% for all cause hospitalisation that was significant. And then a non-significant effect on death, although the effect size was on the right side. Was that what you were expecting, Rajiv?
Yeah, so, the hospitalization and cardiovascular death, I mean, that's a replication of many other trials. In terms of the events per 100 patient years, if you look at just the cardiovascular heart failure hospitalization in the placebo groups in the Figaro trial, mean GFR of 67, it was 1.36 events per 100 patient years. And if you look at hospitalized heart failure in the Fidelio trial, which was mean EGFR of 44, the rate was 2.21. So, here the event is actually a little bit lower because this is a composite event. And perhaps it was, the trial didn't have enough runway, and perhaps these were people who were well treated for. The hospitalization rate per se, 29.2, is extremely high per 100 patient years, because the sick population in Fidelio, where the mean GFR is 44, the hospitalization rate in the placebo group was 23.87 per 100 patient years. So this is a relatively sick population if you just look at the hospitalization rates per 100 patient years.
Yeah, that's I think that's absolutely right, and it says something about those people with low GFRs. A lot of these people did have substantial albuminuria. It is a marker of risk, isn't it?
Yeah, so the albuminuria compared to Fidelio is a little less in, but the eGFR in this trial is a mean of 37, and which is a little lower eGFR than 44 that was in Fidelio. Yeah. So it is the lowest GFR population that we have seen so far, mean eGFR.
Yeah, that's what's so important about this trial, isn't it?
Yes.
So you can see I'm twitching to get onto the eGFR slope. So here's the presentation on the eGFR slope. So what we see, like all the studies in the SGLT2 inhibitors, you see that acute dip. We've seen from other studies that that's reversible. Even after many years in infrared and in Canvas, when patients were taken off treatment at the end of study, there's a bounce back in eGFR. So that initial dip is presumably hemodynamic, it's not injury. So after that dip, we then see, as we did with the previous trials, a stabilization in eGFR slope, so that overall there is a net benefit for people on SGLT2 inhibitors. And here the total difference was 0.75, and that the chronic slope, difference in chronic slope, was 1.37. Now, for strictly when you're looking at randomized comparisons, you should look at that total that incorporates the initial dip. But I think when you're looking at progression of kidney disease, particularly for patients who might be on this for years, it's that reduction in chronic slope, the long-term slope, that's important. So a difference of 1.37 mils per minute there per year, which is important. Is that what you were expecting, Rajiv? Consistent with the previous trials?
So if the total slope is what the regulators focus on. And even there, that's a fairly nice difference, 0.75, that's clinically relevant. And I think that's what we would expect from these.
At median 2 years, relatively short. Of course, safety. We know overall that the safety outcomes from these agents in previous trials has looked fairly reassuring. We saw the same thing here. We didn't get the full safety reporting in the presentation, although there's more in the paper. There was no difference for serious urinary tract infection. That's consistent with some of the previous studies. For serious hyperkalemia, the effect size was on the side of benefit. And we've seen in previous meta-analyses, haven't we, Rajiv, that overall these agents lead to less hyperkalemia, although not independently significant in this single study. And again, consistent with what we've seen previously, reported acute kidney injury events are less in people on SGLT2 inhibitors than people on placebo. So reassuring and consistent with previous studies. The ketoacidosis is an important event. It's rare. From the previous studies, that seems to be more of an issue in the people with diabetes. And of course, there are less of them in this study. There were some events. There were 7 reported overall, 6 in the empagliflozin group. So again, the message for us all is it's rare, but it's something we need to be aware of, particularly because the ketoacidosis can be atypical. The glucose levels can be surprisingly normal or close to normal, unlike traditional ketoacidosis. And then lastly, lower limb amputation was reported. And here there is no significant difference between the groups, 0.8% events in the EMPA group and 0.6% in the placebo group. And I think you're going to say a little bit more about amputation, so I won't dwell on that any further here. So all the results are there consistent with what was known. So the take-home message from all of this, there's we're now with a broad range of people with chronic kidney disease at risk of progression, including people who expanded on the previous trials, more people without diabetes, certainly people with that eGFR down to 20, and particularly people with no albuminuria in that lower eGFR group. In that broader extended population, EMPA treatment led to a 28% reduction in the risk of progressive kidney disease or cardiovascular death. And the results largely were consistent among people with or without diabetes and across those eGFR ranges. All-cause hospitalisation was 14% lower with empagliflozin. EMPA slowed the rate of long-term eGFR decline with similar rates of serious adverse events between the two groups. So consistent with the previous kidney-dedicated trials, but as you said, Rajiv, the really important things were in those populations that extended on the previous trials. So it extends the group that we know can benefit from these agents.